Hello, everyone. I'm Dr. Carmen Puliafito, and I'm pleased to have here today a good friend and colleague, Dr. Dennis Marcus, who is president of Southeast Retina in Augusta, Georgia, and also clinical professor of ophthalmology at Medical College of Georgia, Augusta University. And Dennis is an experienced vitreoretinal surgeon. Welcome to Retina Synthesis.
Thank you, Carmen. So good to see you.
You gave a really fascinating presentation at the ARS meeting about suprachoroidal gene therapy treatment for eyes with non-proliferative diabetic retinopathy and no macular edema. Is that right?
Yeah, there were enrolling in the altitude study were eyes with severe NPDR as well as non-high-risk PDR patients were included without DME. So a DR population without DME.
So can you tell us a little bit about the gene vector that was used, RGX-314? What's its goal?
So the RGX-314 utilizes adenoviral 8 vector, which is hypothesized to induce less of an immune response. And in non-human primate models is thought to have greater efficiency than earlier version vectors such as adenovirus 2 of gene expression. So at least in non-human primate models, greater expression of genes than adenoviral 2 vectors, as well as hypothesized both in the suprachoroidal space as well as the vector itself to induce less inflammation.
And what protein product does it produce?
Produces a monoclonal fragment antibody of anti-VEGF therapy in animal non-human primate models, and is thought to create anti-VEGF long-term expression in retinal cells is the goal with regard to the gene therapy approach.
Is it an analog to any of the commonly used anti-VEGF agents? Like, is it a fragment of ranibizumab?
So it's a ranibizumab-like fragment. It's not ranibizumab. It's ranibizumab-like product anti-VEGF molecule.
What's the prior experience with this drug in retina?
So the greatest experience has been the phase 1/2 data with the subretinal administration. My presentation at ASRS involved diabetic retinopathy and suprachoroidal injection. So the most advanced experience has been with subretinal administration in patients with non-treatment naive AMD. And in the subretinal surgery data thus far indicates eyes that are producing after vitrectomy and subretinal injection with this, eyes are producing anti-VEGF product 1, 2, and 3 years out after subretinal injection. And pretty good data regarding decreased treatment burden and safety. The AVA trial is now evaluating the suprachoroidal RGX-314 for non-naive neovascular AMD, and I presented the data on DR with the suprachoroidal approach with RGX-314.
So what's the physiologic rationale for using suprachoroidal drug delivery of this agent?
So I think that the injection of the suprachoroidal space in the triamcinolone trials for uveitis and DME showed a treatment effect. So obviously we can get a treatment effect with triamcinolone for those diseases. Macular edema with uveitis, I think, was recently approved, and as well as treatment for diabetic macular edema showed some effect. So I think the space, which is new to retina, is a potential space. I think it has the potential for gene therapy as a potential space opposed to the choroid and RPE in the suprachoroidal space to transfect cells, both retinal and RPE, produce the protein in an office-based procedure as opposed to the subretinal approach and vitrectomy. So the advantages are hypothesized to be a decreased immune response within the space. localization of an office-based procedure to allow access to the eye, and some pretty good advanced data with triamcinolone to say, hey, this gets into the eye with at least triamcinolone. It produces an effect for macular edema, both diabetic and with uveitis in the triamcinolone studies with suprachoroidal injection. And now with gene therapy, potentially office-based, hopefully decreased treatment burden in a diabetic population that are at risk for non-compliance. And the pie in the sky is one and done. And this approach with a non-DME diabetic retinopathy population is really, our results are compelling to say, hey, this could possibly be applicable to a larger non-compliant population with regard to prophylaxis. We know that intravitreal injections with anti-VEGF therapy certainly reduces progression and increases regression of retinopathy, but with many injections in a population that doesn't necessarily follow up. So the retina community hasn't embraced intravitreal anti-VEGF injection therapy for DR without DME to a great degree because of the injection burden and the population we're dealing with. And say, hey, this may be an approach if we can obtain longer term safety and analysis of efficacy as well.
What tissues in the eye are transfected by the RGX-314?
I think in the animal models, non-human primates, certainly the RPE, even retinal cells and scleral fiber cells have been shown to possibly express the anti-VEGF therapy. I think that it's hypothesized that the RPE in some retinal cells will produce the fragment and protein in anti-VEGF therapy. And this is some of the benefits of the space and the approach. On the other hand, with any gene therapy, we have to concern ourselves with other cells in the body producing anti-VEGF. However, in at least the non-human primate studies, there didn't seem to be a great effect with systemic transfection. So I think that the space is unique, and the eye, of course, provides us with an exquisite organ to approach various gene therapies. And this is certainly an interesting approach. And the data that we presented at ASRS with 1/3 of the initial at least 15 eyes at this dose of gene therapy, we've got a 33% rate of DRSS improvement, which seems exciting and comparable to intravitreal injections, 3 monthly intravitreal injections. I presented at the ASRS looking back at the panorama data with aflibercept in a severe NPDR group, showed a 40 to 45% rate of DRSS improvement, two-step improvement rate at 3 months after 3 monthly injections. If we look back at the RIDE-RISE data with ranibizumab in a DME population in those patients with severe NPDR, those results 30 to 35% rate of DRSS improvement rates after 3 monthly injections. So if we look at our altitude study, at least initial results at 3 months in DR without DME, a 33% rate in all eyes, including PDR eyes, and in our severe NPDR eyes of those 15 patients, 43% rate of DRSS improvement. One patient had a 4-step improvement, which really indicates proof of principle, I think, at least in the short term, N of 1, but one patient improving 4 steps 3 months after a therapy seems to be significant.
So how long is the study design goes for how long?
So the study's design, the primary outcome is 1 year. I think that there'll be 2-year analysis and probably longer extension studies planned. Additional cohorts at higher doses, cohorts 2 and 3, are enrolling now in both NAB negative and NAB positive patients. And that'll give us a higher dose, safety and efficacy as well. So the safety data that we presented in this cohort 1 at ASRS, and that included all patients And the first patient enrolled at the time of the presentation was out 10 months. So for all patients, the safety data indicated no cases of intraocular inflammation, no cells on slit lamp examination, no vitritis in all 15 eyes treated for all the population. One case of episcleritis was noted 2 weeks after suprachoroidal injection. It resolved with topical steroids, and that was it as far as inflammation. No serious adverse events except in a fellow eye, non-study eye, vitreous hemorrhage, and the usual conjunctival hyperemia and injection after hyperemia and conjunctival injection or hemorrhage after injection not felt to be drug related. So the safety profile so far in this first cohort is very promising with regard to inflammation without any prophylactic periocular, oral, or topical steroids, which is important in the gene therapy literature and experience.
What about the suprachoroidal injection procedure itself? What was the anesthesia technique learning curve on that?
So it's interesting. I think my learning curve is you have to press hard. That's clear that the needle is small, and to get it in the right space and decrease resistance, you have to press harder than you would think. But it's different than intravitreal injection, but it's interesting that the patients, how well they tolerate it, and how well, once you're pressing hard enough, that the resistance lessens and you get the drug in the space. It's monitored by thermal imaging, which is interesting. The drug is stored at -70, so you can, I think at ASRS, I showed a video of mine on an altitude patient showing the spread that you can see that's similar to the animal models that I presented the week prior at Retina Society, that you can really see the spread of drug both circumferentially and posteriorly in the suprachoroidal space using thermal imaging. The drug is cold, so purple is cold, the lid speculum is cold, and you see the warm orange eye, and you can see the drug spread, which is kind of interesting and different. Anesthesia, we've gone back and forth in discussions of the group, and each investigator has a bias and experience. At first, our investigator group discussed, and many of us were suggesting subconjunctival lidocaine injection posterior to the site. It's usually given supero-temporally. As it's evolved, my feeling and some of the group have felt that that's unnecessary and that patients tolerate it well. Occasionally, there'll be sort of some discomfort with the initial injection, but really it's well tolerated like intravitreal injections thus far in my experience. And my bias is not to use subconjunctival lidocaine and just topical.
This is a phase 1-2 trial that's going on, or a phase 2?
This is a phase 2 altitude study going on. So the subretinal surgery was phase 1 and 2 in neovascular AMD. The AV8 and altitude suprachoroidal studies in neovascular AMD and altitude are phase 2, and there's a phase 3 atmosphere study with the drug with subretinal vitrectomy delivery as well in neovascular AMD.
How far away do you think we are from a phase 3 trial of suprachoroidal treatment for diabetes?
I guess if we look at the pace of subretinal, I'd say 2 years if it bears out with these two studies. I would think that in that time period would be the start of a phase 3 if these results were positive.
Well, it's certainly an exciting approach to treating a blinding chronic disease. And it addresses the compliance and drug injection frequency issues surrounding anti-VEGF treatment prophylactically.
Yeah, I would agree, and especially in the diabetic population, and maybe less of an anti-VEGF load is needed if in theory subretinal surgery and application, if in theory produces a greater amount of protein, maybe we don't need it as a prophylactic treatment. Especially this this is a unique approach and a unique population that was chosen. And I think it was fortunate our results thus far indicate this may actually be a very rational approach for this population and disease in a patient with good vision and diabetic retinopathy as opposed to intravitreal injections. But obviously, small numbers, short-term follow-up thus far, and safety is important in the long term.
Well, Dennis, thanks so much for this exciting summary and your great work. And we look forward to hearing more from you in the future.
Thank you
Thank
much,
you.
Carmen. Thank you.